The only way to start your day.
Beautiful. Even right after rising from the sleep. The beautiful is beautiful even right after rising from the sleep. How would you interpret it?
What is beautiful, irrespective of the time of the day, irrespective of the season. If you are beautiful, you're beautiful. And people are going to appreciate that beauty.
Well said.
Indeed. So when we get into this conversation this morning and the pressure, that performance pressure, what are we relating this to?
Thank you. We are relating to a condition we call erectile dysfunction. And by definition, erectile dysfunction is the persistent inability to either initiate an erection or maintain an erection sufficient for sexual performance for both the man and the partner. And it's an important topic. And if you go back, there's a quote by one Roy Tolstoy, who's a Russian writer, who said that man survives earthquakes, experiences the horrors of illnesses, and the pains of the soul. But the greatest tragedy of all time remains and will always be the tragedy of the bedroom. That tells you how important this topic is for many people. And we are here to demystify it so that men can know, one, what are the expectations, and number two, importantly, to know that there is help somewhere.
Yeah. I mean, many hear erectile dysfunction, and I'll just use this and say, ameshindwa kulima shamba, but what exactly is it and what causes it? Because many would say, today, I wasn't in the mood, so I slept. The following day as well, niko na stress, nimeshindwa kuperform. Does that qualify to be erectile dysfunction? Or is it a question that I have to come to Daktari to tell me erectile dysfunction is because of this test we've found?
Okay. Yeah. Thank you. In my definition, I started by using the word persistent. Because if you ask men, at one time in your life, you'll have an experience where perhaps you are very tired, your partner wants to have a performance, and you can't do. So are we going to define you as having erectile dysfunction? And number two, it's good to differentiate it from the other sexual dysfunctions in men. Because we have problems related to premature ejaculation, which is a totally different topic altogether. We have to differentiate it from ejaculatory disorders, and you have to differentiate it from those conditions of persistent erections called priapism. So when you narrow down to erectile dysfunction, like we have said, there are so many things that come into play. Sex is about two partners. Who is the complainant in this case? Is it the patient? Is it the partner? Because you may be thinking you are very well, but your partner is the one saying, this guy has a problem. So when we look at how common this problem is, before we even look at the pathophysiology or how it comes about, it's a question of whom you ask. If you ask the young men, the percentages will be much lower. If you ask the older men, the percentages will be very high. If you ask a cohort of men who are diabetics, who are hypertensive, it may be approaching almost 100%. And therefore, the range of incidence or prevalence of erectile dysfunction may be as low as 20%, but may be as high as 70%, depending on the age group that you're looking at. Number two, it depends on how you ask the question. Sometimes men, we are driven by an ego, and that ego may make us not come out and say we have a problem, even when the problem is very evident. And some men also will come and tell you, I have a problem because he thought he's supposed to last 15 minutes and is lasting 7 minutes. And for him, he's thinking he has ED. Perhaps because he read somewhere, he watched a magazine somewhere, he watched a video somewhere, and he comes with those societal pressures that come with it. Erectile dysfunction, we have to look at the process of erection so that we can understand then how the disorder comes about. One is that you have to think about sex. You have to have a partner in mind. And sometimes the problem starts right from the brain. How attracted are you to this partner? How connected are you to this partner? And from there, these thoughts are modulated by things like hormones. Your hormone testosterone, which is a male sexual driving hormone, how is it in its normal status or not? Then those dots are then transmitted down our body to the pelvis, because that's where the organs of erections are. But that wiring system requires a nervous system that is intact. You may be having a problem in your brain, a stroke. You may be having a problem in your spinal cord, an injury on the spinal cord. You may be having those demyelinating diseases like multiple sclerosis or diseases like that ones, so that then you don't have this information traveling down to the pelvis. Once it is in the pelvis, then it has to be translated to blood flow. You have to increase your blood flow from your general circulation to the organ itself. And this flow is happening through blood vessels. So you have diseases that affect the blood vessels. That's where these issues like hypertension, issues like diabetes comes in. Medications that may shrink the vascular system will come in so that they interrupt the flow of blood into the organ. And then from there, we may have now issues to do with the nerves and sensitivity. Surgeries around the pelvis. Patients have had previous prostate surgeries. Patients have had previous surgeries around the pelvis that interrupted the nerves that conduct within the pelvis, may predispose one to erectile dysfunction. Then you may have to think about once you pull the blood into the organ, then it has to remain within the organ. It shouldn't leak. So you have problems with vessels and valves within the organ that may allow for a leak. And all these contribute to erectile dysfunction. But what is amazing is that 95% of erectile dysfunctions are psychogenic in nature. Okay. They are in our mind. That if you have to investigate 100 patients, only about 5% you find something definitive that you need to do about. So most of the times it will be psychogenic. And psychogenic issues starts even with the relationships. Of course, it also starts even in things like finances. A settle you appreciate as a man, but if you put your hand in your pocket and the only thing you feel are your jewels, it's unlikely that you have an erection that day. But if you have your pay, if you are to conduct erectile function study in a time span of the month, you realize that it's very common towards the mid-month, and when the payday comes, those issues are no longer there because of the effects of stress on the body.
Okay, so what we're saying is that there's a direct link. So this performance pressure that we speak about, even though you may want to, your mind essentially is shutting your body down. Yeah. So are we saying that the only way to realize or to figure out whether it is a psychogenic issue or a purely physiological issue where there might be something going on with the nervous system is to come in and see Dr. Kimani?
Exactly. And in our assessment of the men, we start by interrogating you from your relationships. What are your expectations? What is it that you are calling erectile dysfunction? I mean, that cannot be an erectile dysfunction. It may be a problem of premature. We have to define the problem, what it is. So we ask you questions. And we ask a very important question called, are you having a morning erection? Why? In the morning, the male hormone is at its highest peak. And men are known to love the morning glory. Why? Because the hormones are at their highest peak in that time of the morning. And during that time, nobody has really, you've come up very fresh from your sleep. You are not tired in any way. And therefore, your system is more like on an auto check. And you will wake up, most men will wake up with an erection in the morning. If you're waking up with an erection in the morning, it means, one, your system doesn't have a problem. Okay. Because that's why you have an erection. But it doesn't mean
that if you don't, that your system is having a problem.
It's not an everyday thing. Okay. Because that's what now people also think, that you will wake up every day with an erection. But if you are getting a morning erection, it's more likely that your problem is psychogenic rather than organic.
Okay.
Yes.
You see, Doctor, there's even someone here who's saying tunataka power. You get it? And the power is very important.
Yes.
You know. But then there is the problem then that you find many men find themselves in one or the other unable to perform, right? And because they have not come to Doctor to tell them what's up, so for Doctor to say maybe it is a psychogenic problem that needs to be addressed in a different manner, many just go to a chemist and pop the blue pill, you know, because they say the only way mimi nitapata power is by getting
the blue pill.
The blue pill, you know. What has that done to many men out here who have ended up being dependent on the blue pill? And should blue pill as well just be sold off the counter like any other drug?
Thank you. And that is precisely where the issues are. Who reports erectile function?
Yes.
And that's why I started. Who is the complainant in this case? Because most of the times when I sit in my office, most men, we only come as a last resort because the wife is threatening to go. The spouse, the partner is threatening. If there's no power in this house, I will disappear. And now when the men do come, sometimes it's either because they have been referred to by another doctor. Maybe you've been seeing your psychiatrist and he realizes there's a problem and he refers you. Sometimes it's your diabetologist, sometimes it's your the doctor who's treating your hypertension and so on and so forth. But we want to encourage men to be the ones to seek help because help is available. And when they do come, the first questions we ask them is to try and define what the problem is actually is. Because most of the times when we really ask, I have had young men who come to the office and say, Daktari, I can only last for 15 minutes. And I asked him, what were your expectations? He says, when I saw, it was 30, 40 minutes. And you realize that those expectations are not realistic.
Impossible. Okay.
They are impossible. They are not happening anywhere. And now, sadly, is that many men will... Previously, the blue pill was being sold as over-the-counter medication. And it's not that the blue pill is not safe. Because, again, men fear coming to the hospital because we listen to stories of so-and-so died while they are on the blue pill. The blue pill is a good pill if used for the correct indication, used for the correct dose, and by the correct patient. Now, sadly, some of our men, and I'll say this, erectile dysfunction sometimes give us a window of opportunity to look at your general health.
Okay.
ED is erectile dysfunction. It precedes cardiac and cardiovascular diseases by about 5 to 10 years. A good number of patients will end up with a stroke. A good man will end up with a cardiac attack.
As a result of taking the blue pill?
No.
Okay. Okay.
Because of vascular-related problems.
Okay.
Will have reported an erectile dysfunction 5-10 years ago.
Okay.
Why? Because the risk factors for these erectile dysfunctions are the same risk factors for these cardiovascular diseases. And because you are saying you must have blood flow to the organ. Diseases that affect blood flow will also affect other blood vessels within the body. For example, if you have small vessels within the brain that are not receiving blood, then you may end up with a stroke. You have small vessels within your heart that are not getting blood, you may end up with a heart attack. And therefore, if we investigate you for this erectile dysfunction, which you reported, then we could be saving your life 10 years from now from getting a stroke or from getting a heart attack, because it gives us a window of opportunity to modify what can be modified and make you a better person.
I think it's important that you say this because generally for men, health-seeking behavior is, something that's put on the back burner. It's unfortunate, but it's the truth. So when you say something like this, that even something that which, applies to you psychologically and physically, and in this case, socially as well, then you want to say a problem that you have today that you ignore could have future health effects on you that you could probably, are we saying that you could actually save yourself that future issue if you looked at the present problem?
Exactly. That's exactly what we're saying. If you look at erectile dysfunction and the risk factors, take, for example, the issue of sedentary lifestyle.
Yeah.
You are obese, and I, with all due respect, don't look at the speaker. He's a very active footballer. If you look at obesity, sedentary lifestyles, they are associated with high cholesterol levels. They are associated with risks of diabetes. They are associated with the risk of hypertension. If we managed your weight and we stopped smoking today, then by extension, we are protecting you from getting diabetes. We are protecting you from getting hypertension, dyslipidemias, metabolic syndromes, all of which are risk factors for cardiovascular events. And therefore, if we worked on you today because you came and you had a problem today, we are literally saving you from future disasters. Yes.
You see, Doc, when you talk about men who are under medication, right? So let's say someone is on antidepressants or someone is on blood pressure medication. The side effects would be erectile dysfunction. And you find that if someone went to hospital or even is under treatment, these are communications or exchanges that happen between them and the doctors to let them know because you're going through this would be the result. So when this happens, just come or I will refer you to another doctor who would be able to assist. Yet, these are not the conversations that happen. I'm treating you for hypertension, for blood pressure, and all I do is I give you medication, you go. And these are issues that later then one would find themselves dealing with not knowing where they come from, the origin of this problem. So in terms of the medical field working together, in such situations, so that if I'm treating you for hypertension, I refer you to another doctor who would be able as well to look at what might happen so that you are prepared and you deal with the problem before it happens. Are these conversations that are taking place?
Yes, they are taking place. And importantly is, you talked about hypertension, and I wanted to make a little bit of a clarification.
Yeah.
Hypertension per se predisposes you to erectile dysfunction.
Yeah.
And then there are medications used for hypertension that can give you erectile dysfunction.
Yeah.
And therefore, it is important when you are given a medication that the doctor asks you, do you have problem A, B, C? And number two, we tell you, should you experience side effects A, B, C, please come and see us. Number two is that men, even when they come to the consultation room, he will try to explain his erectile dysfunction without saying he's having erectile dysfunction. He'll come and tell you, Daktari, I have back pain. Daktari, I've been having this bladder pain. My testes have a bit of a discomfort. And you take you round and round. And on the final time when he's about to make a request for some tests, in keeping with the story that he has given you, he mentions, by the way, I'm also not performing. And therefore, we are encouraging doctors, especially those who are in training and those who are in practice, we should be the ones to pose the question. Gentlemen, Aseto, are you having issues to do with erectile?
I am not.
Very explicit,
you don't have to answer now. I mean,
you don't have to answer now. In very explicit terms, we ask you the questions. Are you experiencing problem A, B, C, D? Because only then that will the patient, because if the doctor asks, you find out the patient's now much more comfortable.
Right.
They now want to discuss because that is precisely what brought them to the hospital. But if you didn't ask that question, it will never pop up. Patient will come, leave, go. But sadly, that is the scenario we have been experiencing. But now comes the issues of what then, if we identify that you have erectile dysfunction, should we do? We help you manage things that are problematic. If you're a smoker, we tell you, my brother, you better quit. Because smoking has a lot of side effects that come with it. If you are obese, we advise you, hit the gym. Change your diet. If you're having issues of cholesterol, high cholesterol levels, we may give you something. If you're having hypertension, we manage it. And then over and above now, we go to other now substantive issues. You have nerve problems that are giving you erectile dysfunctions. How do you address those nerve issues? So there are very many ways of treating erectile dysfunction. And like you can guess, because 95% of it is psychogenic, we all need to talk to you. Once we talk to you, it becomes you are calm. And it's best done when it's a couple consultation. Because perhaps the pressure is coming from the spouse, not necessarily from the man. The man, akona power, he has done his honest 3-4 minutes, and he's okay. But the spouse, yes?
Quality work.
Quality work. But the spouse now says, bad. And now that gives issues. And do you know, if a spouse complains about erectile dysfunction, it makes it even worse. Because now the man now develops what we call performance anxiety. Before he comes in the evening, he asks, will the situation be as bad as it was yesterday? So he starts from a point of failure again, which now becomes a vicious circle again. Then there is another funny psychogenic type of erectile dysfunction called situational ED. Situational ED depends on who your partner is. You are very well away, but your home matches, you're losing all of them. That tells you there's no way we are not changing you in any way. There must be relationship issues around that, which needs perhaps to be addressed by a counselor. So it's not all the time that when you come to the doctor is going to give you medication. It may just be talking to you, appreciating what the problem is, and then helping you navigate the problem. And now when it comes to treatment, there are people we put on pills, and these pills are safe. And people sometimes fear and they say, Daktari, don't give me this pill because I've had A, B, C, D. By the time I'm making a prescription, I'll have to look at your risk profile. Do you have any adverse issues that may make this pill a problem? If you combine some hypertension medication and these pills, they can drop your blood pressure and drop you dead. But now, if you bought them and nobody knows that you're taking any other medication, then you are at risk. Besides the blue pill, there are some that are given on demand. Others are given as a daily dose. Others are given hours before because they have variations. And we vary the medications depending on the type of a patient we have. Maybe you are single and you only have a partner for once a month. Why should I give you a daily medication? The other one, you are staying with a partner throughout and you need something every other day. We tailor our medications to your needs. If the pill doesn't work, there are other methods that we go to.
Okay, I'd like us to take a break and come and look at some of those other methods for there to be an understanding. I mean, from what you're saying is that this is not a problem that men need to sit with and not seek help about because something can actually be done. All right, we'll come back and continue with this. Dr. David Kimani is a urologist with the Kenyatta National Hospital. We're talking about performance pressure this morning, and who even knew that there were different kinds of erectile dysfunction. But either way, something can be done about all of them. Let's look at some of the physiological when we come back, and then also see what are these methods that can be used. 28 minutes to 10, Healthy Friday conversation is around this, and one thing that's coming out clear, you don't have to sit with the problem. You can actually seek help. Let's seek it this morning. Don't go away.
This is the Situation Room, the only way to start your day.
Good. And the question of nutrition, Endo, we will look at the recommended diet. We say what is good for the heart is good for the penis.
Okay.
So those things that we advise you to take when you are having hypertension, high blood pressure, and all those things are healthy diet generally.
Okay.
We want to go low on your starch. We want to go low on your fat. And again, it has to come commensurate with exercise and everything so that you maintain your body mass index. That said, there is the issue of uji power, njugu, mukobero, misheveve, and the others. To be honest, when you look at the literature, because they have been studied, including camel soup that has been put forward, there is no difference. They don't have an impact. It is your general overall health and your general nutritional status. So you want to avoid things that are going to push you towards obesity, as it is said. The second bit of it is the issue of substance abuse. Contrary to expectations, the people think that when you have had your 2 beers of Guinness, that you're going to be better. Alcohol increases the urge, but reduces on the performance. So you remove the inhibition to approach the topic of sex. But actually, when it comes to performance, 0. Number 2, bangi, cocaine, heroin, and these other medications have been associated with erectile dysfunction. And it's important that we tell our clients that much because people think that when you have had bangi, that itakuwa tu ni kusiaka. Yeah, but that is not the case. Come the issue of and therefore substance abuse becomes part of our assessment in the sense when you are looking for reasons behind erectile dysfunction in young patients. And when you identify such issues, most of the times there will be a trigger for these substance abuse. And perhaps that trigger is stress-related. And this stress-related will impact on your erectile dysfunction. And those ones we send straight to the psychiatrist for them to have an assessment and help these young men. That is as far as nutrition and substance abuse is concerned. Besides the medications, because besides the counseling, the lifestyle adjustments, the smoking cessation, and all the others, then if we need to give you medication, we give you medication. Mm-hmm. I did not mention that some of the causes of erectile dysfunction is actually hypogonadism, where your hormones are low. Your testosterone is low. Mm-hmm. Maybe you have had a testicular problem. You are born with undecided testes, or you are born with a missing testes, or your testes were affected by previous diseases, and therefore your hormones are low. And if your hormone is low, we assess. We measure the testosterone levels, and sometimes we are forced to supplement. And that is one way of, again, managing sexual disorders. When it comes to the issues of vascular, blood flow, and the likes, most of the drugs that we use are to improve blood flow within the organ, because at the end of the day, what we need is blood flow to the organ. And that's where the blue pill comes in. Then we have some devices that restrict, so that once the blood has come in, it doesn't leave. So we use a vacuum device to suck in blood into the organ and then constrict it with a ring. So there are rings that can be used. Sometimes we use drugs that we inject on the organ, or drugs that we put in the urethra for us to get blood flow accumulating. And all said and done, among us diabetics and hypertension, sometimes we are forced to try and regenerate new vessels within the organ. So it may send you to have what is called shockwave therapy, where we put the organ under some certain stresses so that it can develop some new blood vessels. And in the last part of the tire, because it's a tire thing, you start from the simplest, you go to the most complicated. We do implants, where we put in devices that can allow you to have sex on demand. So it's actually a switch. You switch on, and when you finish, you switch off. But unfortunately, that comes with a lot of cost, and we don't want to get to that point if we can have managed you a little bit earlier.
Yeah. Okay. With this, is the care-seeking behavior for men. It's been a point of conversation in all our health conversations in this studio, that men generally do not show up for these talks, for care, pretty much. And even when they do, you know, tutaenda Singapore kwanza ndio turudi, for us to know exactly where the problem is at. But you find that if we improve our care-seeking behavior as men, then we are able to identify these problems early and deal with them at that point, which then brings me to the question, what numbers are we looking when it comes to men who are generally have come to ask for assistance as compared to the number of men that are being treated? What are we looking at?
I don't have the accurate data, because it's a very difficult topic to navigate, and whenever you ask questions, there will be always biases in terms of the responses that you get. But you're told less than 10% of men seek help. And what is amazing is our men, like especially the African man, has been brought up to be a macho man. You don't complain when things are. You have to act the man that you are, and therefore you end up suffering in silence when you should have sought help. Number two, men are very poor at talking even to other men. They don't open up about their problems. A woman, when she has a problem, she have talked to 6-7 women about her problem. But men, we only meet for a drink, discuss Arsenal, discuss Man U, and then go home. And you go home with your problem. But women have a tendency to talk. And when they talk, you're told, by the way, there is something, I also had a similar problem, or I know somebody who had this problem, and they went. But men rarely do that. And we are encouraging men. Time is now for them to take up their health seriously, because there are things that can be done that can help them, and number two, can protect them against disasters going forward.
You know, you said this conversation is not just for men only, because these men are in relationships, right? And most of the time, if you ask a man to give you a report card of their performance, that would, kofiti, you know, but it is your partner who would always complain. If it's stress that is coming from your partner that is making you unable to perform, that means both of you need to go to the hospital and seek that assistance. So then, how critical then is it for or do we see doctors say, if you have a problem, come with your partner so that we address the root cause of the problem? And how critical is it then for the partner as well to be a supportive partner in this journey?
Very, 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 very good. Sometimes men don't talk even when they come as a couple. And one of the things that we encourage is if a man comes alone, that's a very positive step. We will reassess that man, and if we need to have the partner with us, we will call the partner. Because actually some of the treatments require the presence of a partner. And number two, if your man is not coming, then we cannot ignore him. You have also a duty to push your partner to come and seek help. A man is not going to tell you that when they have situation or ED, he's not going to tell you that when I'm away, I'm very okay. But when I'm at home, because he's literally accusing himself and putting him in a very tight scenario. So they may not tell you about that, which is important for us in terms of making the diagnosis. And therefore, we don't mind when they come alone. But if we need the partner, we always insist on your next visit, please bring your partner along. And especially when it comes to relationship problems, they are best solved as a couple. Sometimes men, you come from Mjengo very tired, and they don't feel like they want to have sex. They have had a very rough day at work, and their wife don't understand. The wife has been in the house, did the house chores and everything. He's just waiting for the husband, give him food, and now demand her rights. And the woman may not understand that this man is undergoing some psychogenic stresses that may lead to erectile dysfunction or non-performance. And what does the wife say? Hey, if you're not, then you must be getting it somewhere, which now compounds the problem. And therefore, that is where the issue of couple counseling comes in, and that is why couple sessions are important. They may not be necessarily the first point, but they are important.
Okay. So, when we look at some of these non-communicable diseases that you mentioned before, diabetes, hypertension, high blood pressure, that will have a predisposition to erectile dysfunction. When do you know? Because you know you have the high blood pressure. Chances are that you are on medication. If you have the diabetes, you know that you have that. When do you know that this would affect and that you're able to combine it as opposed to separating and say, well, it's ED over here, diabetes notwithstanding? Or if you have the diabetes, if you have the high blood pressure, are you then told that these are some of the things that could happen as a result of that? And then what do you do in those cases where you're dealing with an NCD?
Very good question, because hypertension, we said, predisposes you to ED, and ED can come before those other problems. So it's an egg and a chicken issue. And one of the things that we try and do is, one, identify, we say they have a shared risk factor profile. If you look at the risk factors for hypertension, for diabetes, for erectile dysfunction, they are the same. And therefore, if we modify these modifiable risk factors, then by extension, you are handling all the conditions at a go. Number two, we will appreciate that some patients you come already late. They already have an erectile dysfunction, they have hypertension. And they don't know that they have an attendant, or they have not explicitly said, I'm having an erectile problem. It is the duty of the doctor to ask the patient, are you happy with your sexual performance? Are you happy with erections? And if the patient says no, you also take it now from there. So it's a shared pathway in all aspects. And therefore, by treating one, you are also managing the other one. And that's the message. And the issue here is timeliness of that intervention. Because hypertension and diabetes, you have what we call head organ problems, and the pen is one of the head organs. So if you're able to manage the hypertension, the diabetes, to prevent this head organ problem, we will have, one, protected your heart, protected your blood vessels, protected your kidneys, protected your eyes, and at the same time, protected your penis.
Actually, there's a question that has been asked here with regard to use of contraceptives. So whether it's a myth, debunk it, whether it's truth, tell us. There are those who say that contraceptives used by women could cause erectile dysfunction, true or false? And number two, that when a man goes for vasectomy, that is a candidate for erectile dysfunction in the future. Are these myths, or is there some truth to it?
They are very big myths, major myths, and we see them every day. Because what happens to a woman, we are totally different individuals, and therefore what happens to a lady may not necessarily affect a man. So as far as the female family planning is concerned, it doesn't impact on male sexual health. Vasectomy, however, it does not impact on on erectile dysfunction. If anything, vasectomy increases sexual performance. Why? Because the man is not seeing a responsibility going forward. He's not worried that this partner may end up pregnant. And when you are doing a vasectomy, you are not interfering with the nerves. You are not interfering with the blood vessels. You are not interfering with the hormones at all, because you're only tying the conduit, the tube that moves sperms from the testes to the urethra. That is the only thing you're doing. And the studies have shown that actually sexual drive increases in men who have had vasectomy compared to those who have not had.
Okay. So now, the methods that you speak about beyond, I mean, you talked about a device that can be then an implant.
Yeah.
You talk about the pills. And then one of the things that you talk about method is a psychological method.
The biggest.
Right? How then does this work? And we're talking about times when you would go in for counseling, and how long are we looking at? Or is it dependent upon the individual?
It's dependent upon the individual and the nature of the problem. So sometimes we even send you back to your pastor because it's a relationship issue. Then the relationship needs to be addressed, because you cannot be quarreling with your wife and then expect to have erectile function. So the problem here is the relationship issues.
Okay.
Now, if it comes to psychogenic ED, the expectations. Am I supposed to last 1 minute, 3 minutes, 4 minutes, 20 minutes, 1 hour? What is your expectations? And perhaps that is driven by what you know. So if we give you the correct information, that yes, if you give your 5 minutes of honest work and you get to your climax and you're happy about it and your partner is happy about it, you have nothing else to prove. And by dealing with that, then we are able to now move you from the group of complainants, because yours was not actually an erectile dysfunction. It was more to do with a misconception. Once we correct those misconceptions, then you emotionally become healthy. There's an issue of body image issues. My organ is too small. My organ is curved. My organ is this. Yes, when we do a head-to-toe examination of a patient with erectile dysfunction, sometimes we pick in physical conditions that may impact on your sexual function. There are diseases, for example, that causes plaques or calcifications or fibrosis within the penis. And you start getting your penis curved initially, and eventually you now find it's not even getting an erection. It's called Peyronie's disease. We may be able to pick that. You thought it's a normal physiological or age-related change, but actually it's a problem, and therefore the doctor may examine you and appreciate that you have a problem there. You may be having issues to do with the position where your urethra comes out. We call them hypospadias or epispadias, and that required sexual correction, because with hypospadia it comes with a curvature, and with a curvature it makes the penis appear shorter than it would be. It can be corrected. Sometimes patients are born, or boys are born, with what you call a buried organ, and it may give you a very short organ because the hood of the testis is coming all the way to the mid shaft of the penis, and something can be done about it. So sometimes even physical examination may pick an issue that is very easily surgically corrected, and you get along with it. And those are important aspects that why men should go to a doctor and complain specifically about erectile dysfunction, rather than suffer in silence when something can be done.
Yeah. You know, there is also the aspect of these issues being picked at a very young age, even in infants. You know, most of the time you find that the balls have disappeared. I don't know how it's called. It's gone up. You know, and you find these boys, these babies, pretty much in so much pain. So are these things that could be arrested as well, when they're just young children, and be addressed at that particular point? But that does mean that parents have to be keen on the growth and feasibility of their children.
Are you listening to me?
Yes.
Are you a mother of a boy? If you're a mother of a boy, undress him. Look, does he have 2 testes in the scrotum? If the answer is no, or you're unsure, please go see a doctor. Why? When testes are formed, they are formed within the abdomen, just next to the kidneys. And then they drop down to their current location. And in the process of dropping down, a few of them, by the time boys are born, out of 100 boys, 4% that is 4 boys out of 100, have an undecided testis. When you stay for like 6 months down the line, one of them drops. So by the time you're hitting 6 months, then you're looking at perhaps about 3% of boys having an undecided testis.
By when should they descend?
They should have descended by birth.
Or at birth?
At birth,
Okay.
the child should have 2 testes.
Okay.
But then when we usually give ourselves a period of 6 months, because there will be one out of these 4 who had undecided whom is going to drop.
Okay.
So it dropped a bit late. Now, this issue of the testis being in the proper scrotum is designed by God. Because outside the scrotum, we have temperature regulation that is important for, one, maintaining normal sperm formation and maintaining normal hormonal formation. Beyond that, 6 months, then there is gradual decline in the number of sperm cells that are within the testis. And the longer you wait,